Hello and welcome to Onc Now, our oncology podcast series with me, your host, Dr. Jonathan Sackier. Last time out, we initiated a conversation with Dr. Bradley Monk, gynaecologic oncologist from Palm Beach in Florida. Please join us now as we embark on part 2. Hope you enjoy. So, Dr. Bradley Monk, we're back here again with part 2 of our conversation. And just as we did in part 1, I'd like to start off with some quick fire questions, if you will. And you may have covered this before, but maybe you can dream up some other observations because there've been so many developments in your specialty. In a few words, can you name the biggest breakthroughs so far in gynecological oncology, let's say in the last 10 years?
So, again, I have to break it down because we're cancer specialists. We don't specialize in a treatment. We specialize in a cancer. So I'm going to give you 2. Okay.
You're allowed.
And surgery. The idea of cutting someone open is dumb because we can now operate with higher precision, more efficiency, fewer complications, and equivalent or even superior outcomes using minimally invasive surgery. And the Da Vinci robot system, as an example, you can use straight stick laparoscopy, has been revolutionary. And so it's wonderful. I do hysterectomies today and send the patient home from the recovery room. Okay. And so we use, enhanced recovery, ERAS, if you will, very, very transformational. When it comes to systemic therapy, I really can't pick out the one other than to say it's personalized therapy through biomarkers. Because we can do a biomarker and tell you which ADC, mirvetuximab soravtansine, or trastuzumab deruxtecan is going to work. We can do a biomarker and tell you what the impact is using a PARP inhibitor, using the homologous recombination repair deficiency or the BRCA gene. Okay. So precision medicine, helping the patient understand the risk-benefit ratio in utilizing these novel targeted therapies and even immunotherapy, if you will, because even in immunotherapy can use DMMR, mismatch repair deficiency, tumor mutational burden, and microsatellite instability is another opportunity.
So, bringing a historical perspective, if you could have dinner with any figure in medical history, who would it be and why?
So again, my history started out in cervical cancer. I grew up along the southern United States border and Arizona and went to California and worked in even Texas. And now I'm in Florida and I see a very diverse population. And really the signature on block operation that we do in gynecologic oncology, the operation that you try to learn is called a radical hysterectomy. And in fact, the first operation I ever saw as a student was a radical hysterectomy, and it was the inspiration. And I've had the great pleasure to receive the Wertheim Award because Ernst Wertheim was an Austrian gentleman that sort of pioneered that operation. And again, I was privileged enough to receive that award, which is given annually to a key opinion leader in cervical cancer. And I'd like to have a Frühstück or cafe with Ernst Wertheim, my Austrian predecessor.
Maybe a slice of Sachertorte as well.
Yeah, there you go. Wiener Schnitzel or something.
There you go. Absolutely. With or without a poached egg. That's the key.
That's right.
So what's one myth or misconception about gynecologic cancers that you often find yourself correcting? Whether it be patients or
yeah, it's easy. It's easy. So, and I had the pleasure of being a medical student and working in the laboratory at the National Institutes of Health that developed Gardasil, the HPV vaccine. So I've been passionate. You mentioned it, that this is a virally driven cancer. And if we learned anything from COVID, right? If you don't want to die, you should get vaccinated. It's literally that simple with cervical cancer. If you don't want to die of head, neck, anal, vulvar, vaginal, cervical, just get vaccinated. And the HPV vaccination, which now covers 9 HPV types, 2 of which are wart-related, it's safe. There's no mRNA and autism and all of that. Seriously? And here's the misnomer. The misnomer is that you have to be sexually deviant or promiscuous to get HPV. The only thing that you have to do is be sexually intimate. And the greatest woman in the world, my mother, has had sex at least twice because I have a brother. And if you would ever say that she was deviant or promiscuous, you would be a liar.
Yeah, it's profligate. It's all over the place. And you know, I've had friends who've had,
Of course.
and there's this, you know, there's almost this shame about it. Well,
There's no
it's
reason to be shameful. That's the misnomer. That's the false news, the fake news.
I wish I could go back and have a conversation with the people who first accepted the paper by Wakefield that led to all this nonsense about vaccine hesitancy. I'm with you on that.
That's right.
So let's dive into some more in-depth questions relating to the Society of Gynecological Oncology annual meeting in 2025. But first of all, what took you into gynecologic oncology? Clearly a smart guy. What took you into this specific specialty?
Not so smart, but hardworking. Again, it was seeing a radical hysterectomy. And what happens as a young individual, you become enamored with the tangible surgery. You can touch it. You can have an action with a result. I can't believe that I was so naive. There is nothing worse than taking a sharp instrument to a person. It's called surgery. Okay. So the idea is to avoid surgery. And so I've evolved my career into that, but I became an OBGYN doctor to become an oncologist, to specialize in cancer. And initially we are infatuated with surgery, but that's the wrong approach, because we should be infatuated with innovation and discovery, less minimally invasive surgery, surgical de-escalation, and be more focused on cures and personalized treatment.
Actually, it's interesting you commenting on the first operation that caught your attention. The first that caught mine was for a patient who had ulcerative colitis and had a total colectomy.
There you go.
Ileal pouch, and it was transformational. That took me in the direction I went. So,
but think about that. You got excited because you cut out a person's colon and made them excrete their entrails into a bag. Really? There's nothing good about that.
This was with an ileal pouch.
Oh, an ileal pouch. Oh, okay, good. So they just had dumping syndrome the rest of their life and short bowel syndrome.
4 episodes of defecation a day instead of 20. So,
yeah, there you go. Right. I hear you.
It was the approach, but like
I hear you.
Fascinated by minimally invasive surgery. So let's get on to the meeting. SGO 2025, the DUOE trial results were presented, highlighting the role of, and I have to tell you, I have problems pronouncing any of the monoclonal antibody drugs. My brain can't do it.
It's okay.
Durvalumab,
or just call it Durva.
There you go. And olaparib in endometrial cancer. How do you interpret? I don't know why I've got a mental block about them. How do you interpret these findings, and what implications do they have for clinical practice?
Yeah, it's a complicated question. It's really easy to examine things through the rectospectoscope, looking backwards. It's very easy to say, well, we should have done, I wish we would have done. Durva or durvalumab is an anti-PD-L1 monoclonal antibody that basically is immune checkpoint inhibitor, one of more than a dozen now that we have in the clinic. It's a good one. It has several indications. The current indication in endometrial cancer today is only in MSI DMMR. I mentioned that there are others in the all-comer dostarlimab and pembrolizumab. I also mentioned that as we evolve, we sort of go to earlier lines of therapy. Remember, immune therapy was first approved in recurrent DMMR, and then it was approved with lenvatinib in recurrent pMMR, and then we moved it to the front line in the DMMR and then into the pMMR all-comer. But the next phase is combinations. I think that PARP inhibitors work in tumors that repair double-stranded DNA breaks poorly. And that's what we call homologous recombination repair deficient. When our DNA gets a double-stranded DNA break, it aligns one chromosome, the normal one, with the broken one homologously. It uses the template of the unbroken sister chromatid and repairs them. So that's called homologous recombination repair, or HRD. We can measure that in ovarian cancer sort of indirectly through an HRD test for PARP inhibitors. The other sort of activity that predicts homologous recombination repair deficiency as well as PARP sensitivity is platinum sensitivity, because that's what platinum does. It creates platinum adducts to the DNA and it breaks the DNA. So it's sort of a relationship there to PARP inhibitor-induced double-stranded DNA breaks and platinum-induced double-stranded DNA breaks. And I haven't said it, but what PARP inhibitors do, PARP inhibitors inhibit single-stranded DNA repair. And if you inhibit a single-stranded DNA repair, it becomes unstable and breaks the DNA. And that's how PARP inhibitors work, and platinum cause apoptosis and cytotoxicity. So in endometrial cancer, the idea was to take platinum-sensitive endometrial cancer and as a surrogate biomarker and add olaparib in the maintenance phase, just like we did in the New England Journal several times with ovarian cancer. And because immune therapy was coming, dostarlimab, pembrolizumab, and now durvalumab, to add them together. And there was a 3-arm study done called DUO-E. And it was challenging because we didn't know what we know now then. It's the retrospectoscope. And so the design of DUO-E is complicated because it's 3 arms. And when you have 3 arms, do you compare every arm to every arm? And how do you sort that out? And the way the study was done is it took chemotherapy alone, which has been the standard, and compared it to chemotherapy, durvalumab. Pretty simple, 2 drugs versus 3. And then it took 4 medications, chemotherapy, durvalumab, and olaparib, and compared it back to the 2 drugs. You say, well, what about the 4 versus the 3? Well, the study wasn't big enough to do that. Again, maybe we should have done that. And then you say, well, Monk, you just told me that immune therapy works better in the DMMR MSI versus the PMMR MS stable patients. Did you divide those up? Yeah, not really. And then you say, well, I thought immune therapy works in the PD-L1 population. How was that integrated into the study? Yeah, well, we tested it, but we didn't really make it analytic. See, what happens in clinical trials, every comparison could be different by chance, and that's called alpha, and you have to compare for it. You have to compare for multiple comparisons. And you can't just do a study and look at everything and, oh, that's it, that's what worked, and now we like that. It's called a primary endpoint. Okay, it's called a stratification factor so that the arms are balanced. And we didn't know how to do that when the 3-arm DUO-E study was designed. Having said that, immune therapy works so amazing in the mismatch repair deficient that led to FDA approval. The 4-drug regimen, again, the 4-drug regimen wasn't compared to the 3-drug regimen, meaning what's the real incremental benefit of adding olaparib to durvalumab? Well, we didn't really do that formally. We did it post hoc, and it looks pretty good, particularly in the mismatch repair proficient non-DMMR subset, but it wasn't pre-specified. So there are people that are very, or more, not very, but more analytic than others. There are others that are sort of more reasonable and say, look, Monk, come on, look, it shows, come on. Olaparib's good medication. It combines well with durvalumab, and you can see a clear signal when it's added to durvalumab in the PMMR subset. So come on, Monk. I mean, don't hammer me on this result. So this creates the controversy. So there are more rigorous individuals, such as the US FDA, that have not approved it. There are other regulatory authorities, such as the EMA, that has approved the 4-drug regimen. Now, what happens is that the 4-drug regimen, even though it may be approved by the EMA, doesn't mean that it's going to be reimbursed in Italy and in Spain and France. It does mean, as you know, because the German economy is what it is, that generally that is those EMA approved are reimbursed in Germany. And obviously you paid attention that the UK is no longer part of Europe, so the UK makes their own decision. And then there are other parts of the world, such as the Gulf countries, Dubai, Kuwait, Bahrain, Qatar, that if it's EMA approved, it's also reimbursed. So now all of a sudden, when you ask me what the interpretation is, it doesn't matter what Brad Monk thinks. It matters what the FDA thinks. They didn't approve it. It matters what the EMA thinks. Well, they approved it, but the reimbursement is country specific. It matters what they think in the UAE because it's approved because they follow the EMA and it's reimbursed. So it's not a simple answer, but the truth is that PARP and IO can be combined safely, durvalumab and olaparib, and there's a signal. And there's a signal in the highest unmet medical need, the patients that are not MSI high, because they only need probably just checkpoint. And the highest unmet medical need is the non-MSI mismatch repair proficient. And there is an opportunity to consider adding olaparib to durvalumab in the maintenance phase. So you start with the 3-drugs chemotherapy, durvalumab, continued in maintenance, and then you add olaparib in the maintenance phase if the patient responds to platinum, because that's a surrogate.
Fascinating, interesting perspective. And I know from prior interactions with Food and Drug Administration that there is a focus on patients in clinical trials coming from the United States of America.
Mm-hmm.
There are certainly differences in disease biology. We know that from other cancers, and there's difference in the demographics of trial populations, and there's difference in healthcare systems that impact this. But data are data are data. And it's very hard to comprehend when this sort of a situation arises, as it has done many
That's
times
right.
over the years.
And people ask me, well, Monk, what's your opinion? And I already said my opinion doesn't matter, and I'm going to stand by that. But I can tell you that I'm an advocate for people, and patients need options.
Yeah.
And then people say, well, this is expensive therapy. And I say, you're right, healthcare is expensive. But that wasn't the question. The question is, should this be available to patients? And I think patients who are fighting cancer and a high unmet medical need, mismatch repair proficient, need options. So that's what I think.
Yeah. Do you ever have patients who go overseas to seek it?
Well, you can olaparib is right here in ovarian cancer. It's just you're not going to walk into Germany and say you're a German citizen and pay for my health care. So that doesn't really work. There are medications that are not available in the US, and then you have to go to other countries. But the medications are available. At some level, it's really driven by reimbursement.
Yeah.
The sort of the, I don't know if it's a trick, but what happens is that the NCCN guidelines, they have level 1 preferred, and that's pretty straightforward, but they have sort of a weaker recommendation, level 2. And the level 2 is bifurcated, 2B, 2A, and 2A is pretty good. And generally, if it's 2A, it might be reimbursed. And this quadruplet is not quite there yet. But, over time, like at the Society of Gynecologic Oncology, and that's what we're talking about, that's why we're presenting this. And it was also presented at the European Society. That's why we represent, because the data matures. What was presented there, and it'll be presented again at another major scientific meeting. I almost told you the name, but I won't. I'll let you show up and see it. You'll see that the data set is so extensive and rich that it wasn't included in the first paper. It's just not feasible, and it matures, and the molecular biomarkers are analyzed, and that's what you see at these more recent meetings.
Okay. Well, so going back to the meeting, what are three most impactful insights from SGO 2025 that you've not covered off that you believe will shape future research or treatment strategies in your specialty?
So the SGO happened in close proximity to ESGO.
Right.
And so the science was not substantially different, but the attendees were different. So it, as you know, travel is expensive. It takes time off work. I get it that there's a virtual option, but the science was not substantially different necessarily in the SGO. And similar to what we talked about at the ESGO was Key-Link and PARP and IO and ovarian cancer, and obviously IO and cervical cancer with chemotherapy and radiation in A18. We just talked about DuoE, but also the expanded indications in Keynote 868, which we call GY018, and also the Ruby trial.
Right. So, well, let's change topic. I've been having lots of conversations recently with colleagues from many specialties within medicine about the role that artificial intelligence is playing, most recently with thoracic oncology, and thinking about interpreting what lung nodules look like on CT scans. Are they or are they not likely to be malignant? How do you foresee the integration of artificial intelligence, large data sets, transforming the landscape of gynecological oncology?
Yeah, it's a good question. I think we're in the infancy stages here. I look at the best value today of AI, of clinical trial matching. So where I work at Florida Cancer Specialists and Research Institute, probably the largest practice in the US, we use AI to go through the electronic medical record and the complex eligibility criteria of a clinical trial and try to match them. The biomarkers, all of that. That's probably the most common interface of AI in my practice. And again, I'm a clinical trialist. And I'm the medical director of clinical trials here at Florida Cancer Specialists. The challenge that I find with AI, unlike people, they don't know when they're wrong. So you have to go back and you say, listen, AI, this just happened. That cervical cancer that you said was eligible for the clinical trial, well, actually, it was a cervical lymph node from a lung cancer. Wrong. That cervical cancer, which was in the uterine cervix, was actually a uterine cancer involving the cervix. So AI has great potential, but you have to teach that the cervical lymph node or the cervical cancer in the uterine cervix was growing down from the uterine cavity. So I think we have a long way to go. I'm the GYN editor for Annals of Oncology. It's a high priority for us to publish more data and information about how AI is integrated. But I think we're really in the early stages of AI in oncology.
Yeah, certainly imaging is an area, surrogates for clinical trials, as you say,
Mm-hmm.
clinical trial selection, medical record improvement, lots of things are happening. But for the meantime, probably reserve it for planning your vacations. That's certainly what I use it
Oh,
for.
I don't need AI to know that I want to go. I want to go to Budapest and Vienna in a month.
Yeah, both wonderful cities
Yeah. Uh-huh.
indeed. Final question for you. We ask our guests, if you had three wishes in your area of healthcare from a magical genie, what might those wishes be, Dr. Bradley Monk?
Yeah. So we have a president who has taken the word DEI out of the lexicon. You can call it whatever you want, but we need universal health care for everyone. If a person is ill, infirm, they need access to potentially life-saving surgery, radiation, chemotherapy, whatever. And at least in my country, we have a healthcare system that is broken. If I had my druthers, I would prefer some sort of national health care. We are one of the richest countries in the world, but we're not rich enough to take care of our citizens. And that's highly disturbing to me.
Yeah, it's I as I said, I spent half my life in the United States and practiced over there. And what bugs me, and so I've practiced on both sides and I've traveled to every continent to teach and operate. What bugs me is that it's impossible to have a conversation. Americans will tend to sneer at the National Health Service and call it, quote, socialized medicine. I never knew what that was. And British people will sneer at the failures of the American healthcare system instead of doing what we should do. And as the great American comedian who I love, Bill Maher, and political commentator, why can't we just get in a room and say, hey,
Yeah.
Americans, you do this really well. Hey, British people, you do this really well. Could we take some of the best of both systems and bring it to the people that we actually are committed to look after, which is frankly all of us, because we're all patients sooner or later.
Yeah. But
Um,
it's contaminated though by money. And
yeah.
you know, whether you're Christian or not, there's this thing that we call the golden rule.
Hmm.
And the golden rule should be do unto others as you would, you know, have do unto you. But the real golden rule is that he who holds the gold makes the rules. So we need to get back to the real golden rule and get away from the false golden.
Well, I hope you enjoyed that conversation with Dr. Bradley Monk as much as I did. Please consider subscribing on Spotify or Apple Podcasts or wherever you get your podcasts so you never miss an episode. Please like us, leave a